All right, good morning, everybody. So I think we'll get started. Welcome to Medicine Grand Rounds. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Dakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others, whose histories, languages, and cultures continue to enrich our vibrant communities. So welcome everybody to the highlight of the Division of Gastroenterology's year. This is our premier Wensel Sherbaniuk Lectureship. So I'd like to start by saying a few words about our sponsors. So as a reminder, both Drs. Wensel Sherbaniuk were graduates of the UA. Dr. Sherbaniuk graduated here in 1952 and started on staff in 1960 before there was even truly recognized gastroenterologists in the country. And he had the passion to believe that gastroenterology was going to be a budding force across the country, in which it is. Dr. Wensel joined in 1964, and the two of them started the division in 1967. So again, for all of us that are here, we are in their footsteps following this. Some other notes as well. They were on the first board of the Canadian Association of Gastroenterology, a strong Edmonton link as well. Dr. Alan Gilbert and Dr. Mackenzie, familiar names here, were also on that first year board with Dr. Sherbaniuk. So a lot of links to gastroenterology come through Edmonton. So it's a pleasure to present our lectureship appointee this year, our winner, good friend, and Marla. We've known each other for almost 30 years. It's kind of scary to say that. So Dr. Marla Dubinsky, she's a professor of pediatrics and medicine at the Icahn School of Medicine at Mount Sinai, New York. She received her medical degree at Queen's, and she completed her pediatric residency at Children's Hospital in Calgary. And she then went on to do further training in gastroenterology and nutrition at St. Justine Hospital at University of Montreal, Canada. And then she completed her research fellowships in IBD at Sinai in LA, where she served as a pediatric chief eventually. Also at the Mount Sinai Kravis Children's Hospital, and she's also the co-director of the Susan and Leonard Feinstein IBD Clinical Center. She's a co-director of the IBD Preconception and Pregnancy Planning Clinic at Mount Sinai, and she's also the co-founder of MyTest Health and Cornerstones Health, which is a nonprofit organization dedicated to enhancing and transforming communication between healthcare providers, patients, and industry. And then she's now the co-founder of Trellis Health, a healthcare technology company delivering digital resilience platform that transforms the way people manage chronic conditions. So on a personal note, in some ways, Dr. Dubinsky, you're very similar to when we first met. You're driven, you speak your mind, and you know and you want quality. And I think in some ways.
Thank you so much. Again, what a pleasure to be here. Being someone who trained in Canada and left, always love coming back. And thank you for the opportunity. So I was asked to give somewhat of a provocative, thought-provoking talk. So I thought, what better than talking about the fact that are we on the road to preventing inflammatory bowel disease? The concept of how are we looking towards preventing chronic illness and how are we going about road mapping this out? So hopefully I'll be able to share with you where we are literally as of today and all the work that's being done to try and figure out, like type 1 diabetes, we've just recently seen a regulatory pathway with the FDA, for example, on how to test drugs in prevention or delaying onset of diagnosis of diabetes. IBD is taking a lesson, a page out of their book and trying to actually apply that concept to IBD, which is fun and allows you to dream really big. And so hopefully I'll make this argument as to why this is important. Last night we spoke about how to manage people with IBD because there's still, 3 million North America wide pretty well, 10 million worldwide and growing. So there continues to be a need to also think about tertiary prevention, which is treating those patients with already diagnosis. But we're going to talk about secondary and primary prevention and actually the fact that there are true trials actually happening as we speak in people at high risk of developing IBD and treating them with even a biologic. Shocking. So we'll move towards sort of making the case, hopefully, as to why this is important. And as I noted, we're increasing prevalence and incidence, particularly ex-US or ex-North America in terms of increasing prevalence. We're seeing the highest group of fastest growing new cases in children. So there's somewhat of an urgent need to actually try and understand what's happening. Obviously, environmental is changing, and what is it about environmental triggers that maybe we can start to protect people who are at high risk of developing IBD. We're not talking about going to the mall, for example, and implementing general sort of prevention processes, because it's still not a very common disease, although it is not uncommon. It is not sort of everybody at the mall would be at highest risk of getting IBD. So really where IBD focus has been on those folks who have the highest risk of getting IBD, most notably first-degree relatives. So I'll be walking you through sort of the concepts that's happening, particularly in at-risk individuals. We know that drug-free remission is really seldom possible. This is a chronic incurable condition until proven otherwise that requires ongoing treatment for the majority of individuals. There's a few patient types. We've all seen patients who had surgery 30 years ago, haven't had a recurrence, doing absolutely fine. But again, that's not the most common thing that we see in our practice, right? We see people who need chronic conditions. We know we're dealing with high surgical rates. And most of all, there's such a high mental health comorbidity with our patients, not just the ones in the hospital, but there's a lot of outpatients who are suffering in silence with anxiety, worry, stress, low resilience. And also, so the idea that if we know from some of the work that have been done, that when you intervene early in people with a known diagnosis, you get better outcomes. So the idea is, can we go even earlier? And who is that person? And when do we start to implement changes? So the way that we treat, unfortunately, inflammatory bowel disease is we often wait for people to complicate and go, wow, you've got complicated Crohn's disease. I'm now going to pull out one of the best therapies we've ever had. Problem is we're using therapies to prevent complications. So if we're waiting for patients to complicate or develop what we deem to be severe disease, we've sort of missed our window, right? So there's been a huge push in the IBD space to talk about this window of opportunity. And, you know, when we think about breaking the therapeutic ceiling, because we talked yesterday that the net remission rate, which for us means at the end of the year, someone who starts on a drug, how many patients are going to be in remission at the end of the year? Less than 50% of our IBD patients in clinical trials actually meet the outcome of disease remission in a clinical trial. So the opportunity or the therapeutic, ceiling is definitely needs to be broken. And we have a whole smattering of different ways that we talked about it, maybe combination, maybe new therapeutics. But at the end of the day, it all still comes down to timing and early and speed, in a sense, to getting that therapy on board. So we try to talk about early intervention. That still is tertiary prevention, because these are people who are diagnosed and we're sort of moving in and saying, hey, the way you can prevent someone from having a complicated course resulting in surgery, disability, chronic bowel damage is to hit them early. And so there was a study that sort of a second study, there was one a lot earlier, 2008, but the concept has begun to gain some momentum across many symposium and conferences. People have shown this profile study as if it's revolutionary, but the idea that someone within 2 weeks of a diagnosis was given an approved effective therapy was a shocking revelation. And mainly because, to be fair, in the United States, that less than 15% of Crohn's patients are given an advanced therapy within years of diagnosis. And in ulcerative colitis, it's less than 6%. So people are the majority of folks are walking around using drugs that are not approved for, but seem to be perceived as safe, not understanding that the biggest safety risk for an IBD patient is the disease itself. There's no therapy where the risk ever outweighs the benefit, right? In terms of the potential complication of the disease itself, particularly in Crohn's disease. So this therapy sort of said, if you give everybody within 2 weeks of diagnosis an approved effective therapy, the drug that they used in this study was infliximab, which is something we've had since the late 90s. And so what they basically looked at is when you sort of take patients where you give them good therapy upfront versus use a little bit of this, give more steroids, try and wean the steroids, then give a little bit of that, and then go, oh, I think you finally need infliximab. That's what step-up therapy is, and that was the comparator. So the idea that if we can move our treatments early and change the trajectory, what happens if we moved it even earlier than that? And that's sort of this preclinical concept of prevention. And so when we talk about sort of this ability to intercept, taking someone who has biomarkers that may suggest that they already have bowel epithelial damage, there's already something has been stimulated, the microbiome has crossed through the epithelium, there's some inflammation going on, not clinical yet, right? The person has not progressed to coming in with abdominal pain, diarrhea, urgency, rectal bleeding, whatever the symptoms are that they're coming in with, perianal fistulas and Crohn's disease, is that the idea is that can we actually intercept a process that has begun, triggered by something. Just a reminder to everybody that like most autoimmune diseases, IBD is a genetic disease. You cannot get IBD without a gene. Doesn't mean there's one gene, by the way, there's hundreds, which is why we don't have a cure, which is why, and there's gazillion environmental triggers, which is why we don't have a cure, you know, and the list goes on. Like any complex polygenic autoimmune disease, it makes it difficult to cure. So the closest thing, at least for now, while there's still a ton of work being done on trying to understand it, before we get to cure, we have to understand this process and actually understand what happens before someone presents with a diagnosis and overt clinical symptoms, and that's in that early stage of preclinical. Why is studying the preclinical phases important, and particularly in IBD? It's not different, I would venture, in diabetes. I'll show you a little bit about their roadmap in just a sec. But it really allows us to understand disease pathways so we can look early and actually map out the process that is actually happening in a high-risk individual, from initial pathway-driven inflammation to the next, etc. It also helps us understand maybe the targets a little bit better about where our intervention strategies may want to target. If it's a virus, is that something we can target early on? If it's a retrovirus or EBV, in case you didn't meet Dr. Mason, that's a thing. Biomarker for risk stratification, the ability to actually figure out whether these biomarkers happen and change over time, to be able to say when someone gets this autoantibody, for example, in an asymptomatic individual, is that the start of IBD? Like in diabetes, asymptomatic antibodies, multiple, that's sort of the preclinical stage of diabetes, and it's almost certain the more of these antibodies you have, that you will progress faster to clinical diabetes, right? So this concept is very similar to inflammatory bowel disease, and we've sort of taken a page out of their roadmap. And also, of course, if we understand all of this, it helps us lead to some prevention intervention. So as I noted, we're going to really be focusing on the primary prevention as well as secondary, which is those populations at highest risk who don't have any signs of preclinical inflammation as measured by a biomarker, for example, and be able to maybe prevent and or use the term interception for those who have started down the inflammatory pathway, even though they're not clinically at this point presenting as IBD. I'll be honest, the use of intestinal ultrasound is a really important tool in the whole prevention story, because you may see these signs in the bowel wall long before someone presents with clinical symptoms. Similarly, if you dropped a capsule, like the group in Israel are using capsule to actually look in individuals that are high-risk individuals, suggesting that small bowels, apthi, which wouldn't present with overt clinical diagnosis or MRE findings, it's very superficial, that maybe there's hyperemia in the bowel of individuals who start to have these aphthous ulcerations early on. So the application of ultrasound is also interesting in these high-risk groups, and I'll show you how we're applying that in the clinic. So there are four sort of specific elements that we're going to be focused on. The first one I'm going to talk about is, how do we find predictive biomarkers? Like, how can we bank that this marker predicts the onset of IBD, right? That's the first step, because if you don't have anything that actually divides me into a high risk versus a low risk individual that I can bank on from a predictability perspective, none of this really matters, because if I can't sort of find a tool that predicts that this individual is high risk, then it really makes it complicated in ability to develop prevention. And I did definitely sort of highlight once the diagnosis, you're talking about treatment, and everything before that is either prevention or interception, right? Intercepting the clinical process. So there are a handful, not bad. I'm showing you sort of 9 or 10 different cohorts out there that have been trying, and we still continue to try, to look at how do we develop these biomarkers and how do we actually find individuals at high risk so that we can test this prospectively, so that we can take a whole bunch of stuff from retrospective cohorts or those of us doing prospective cohorts and then be able to validate this. So I'll walk you through a couple of these cohorts, but you can see here, some are prospective where we take individuals and we follow them prospectively. I'll show you some of these cohorts, which are probably really exciting and sort of the highest risk cohorts you can imagine. What we're seeing in terms of in New York specifically, I'll talk a little bit about our high risk population in the Orthodox Jewish community, which is the highest risk population in the world. Just because of genetics, but there's also a particular sector in the Orthodox community called the Satmar community. These were the original 200 or 300 families that survived the Holocaust in Satmar, Hungary, moved over to the United States, particularly in New York, and are very, they live in their own community. So there's a lot of genetic sort of marriage and very much contained in a select environment. So it's a really interesting population to look at because they would have family sizes of around 10 to 12, and they will have 4 or 5 of the kids that have IBD. So it is a enriched population of both genetics, but also environmental sharing. Often there's one bathroom, a lot of, and the older individual leaves the home at 18, for example, but then you have a newborn potentially, right? So there's just the ability to look at whether or not there are shared microbiome between the youngest sibling and the oldest. So there's some really interesting environmental stuff that we're doing. The one cohort that I think most of folks are familiar with is because it was started, in Canada, the GEM cohort. And I think you guys are part of GEM, if I understand. So these were taking first-degree relatives of somebody who has IBD, particularly. Wasn't necessarily having like the Orthodox families where you had to have multiple families to get into the cohort. This could have been just one affected individual. And following them over time, there was stool, there was urine, and blood. And this was how it originally got sorted, is that the goal was 70 cases to allow for a risk parameter odds ratio of about 2.5. And the baseline risk was noted to be 0.3 per year, right? That's the baseline risk for Crohn's. So a couple of key findings from Ken's group and the other researchers looking at biomarkers of risk. So what they did is they collected all this at entry of the first degree relative and looked over time. They didn't get necessarily serial sampling or didn't get it at the time of diagnosis, which is sort of where we're trying to fill the gap, because it's one thing 2 years ago to have been enrolled and you had a certain serum, urine, or blood profile. What happened serially over time? We have a few serial samples, but not routinely serially at the time of diagnosis to even know what's more important 2 years ago or what was actually happening at the time of diagnosis. But either way, when they looked at gut permeability, they were able to show that those individuals at enrollment who had a more leaky gut at the time actually increased the odds of getting IBD. So that was one of the ways to think about that. You could way back in time predict somebody with more certainty that they would get IBD. They also looked at serology, so autoantibodies, which are something that's been around in the IBD space since like the late 90s. Is my first fellowship project was on serologies, looking at it as a diagnostic tool. Not very important, but it was important at the time, of course. But I'm saying now, serologies, shocking I got anywhere. But yeah, so serologies are now really thought to be, one, a biomarker of severity, meaning more prognostically, people have looked at these antimicrobial antibodies, things like ASCA, Pianka. There's just certain antibodies. And what the group showed is that actually these antibodies raise years before the diagnosis. And so are these, like diabetes, these asymptomatic autoantibodies, are these really predictors of high risk of getting disease? And we believe that it's probably a reflection of bacteria leaking through, the body sort of responding with an autoantibody to probably loss of tolerance, right? Our inability to tolerate maybe our gut microbiome, which, by the way, is the underpinnings of IBD in a sense. In a genetically susceptible host, no longer tolerates or symbiotic with our own microbiome, and inflammation incurs and we can't shut it down. That's basically, and that's what we use treatments for, right? Is to shut down that uncontrolled inflammatory response. So they've been looking at multiple different ways to predict. Speaking of predicts, there's this really interesting cohort that I was talking to Dr. Mason about yesterday, is the US Army cohort. So in the US Army, at the time that you enter from the Department of Defense, you get blood every 2 years. Now, you can't get into the Army with IBD, so no one started with IBD. And they checked, well, no one knew that they had IBD, I should say, at the time of entry, okay? And then every 2 years, they would collect serum. And so there has been a multitude of work that has been done on this cohort. Now, they actually have this data for any disease, which is kind of cool too, that you can look across any disease and see whether or not, how soon before diagnosis some of these markers are present. And although my antibody story wasn't as necessarily interesting for diagnosis, but it kind of makes sense because it actually is present out to 10 years before diagnosis in these folks who entered the military. So these autoantibodies, again, in keeping with the theme of diabetes, these asymptomatic autoantibodies are present long before diagnosis. So there was so many different things that we looked at in the predicts, but I'm just showing you there was virome, metabolome, exposome, proteome, these antibodies that I'm talking about. We also looked at the glycome, which has gained a lot of interest. These are the publications. And just to let you know that it started in 1985 after mandatory screening for HIV. And the HIV protocol would be every 2 years you get serum. And so it just so happened that serum is sitting, large number of serum samples, large, that's an understatement. There's over 60 million samples that are sitting in this repository. So you can imagine it's really an incredible opportunity to study stuff before stuff happens. So the Predicts, one of our first publications, was looking at the autoantibodies I was noting, the same antibodies that Ken and the GEM group found, ASCA, ANCA, OMSI, CBER. These are just sort of antimicrobial antibodies. But they were the first to look at somologic, so looking at protein expression and looking at whether or not using a serum predictive tool, meaning, because we talked a little bit about tissue and whether that's like, or poop. Not everyone likes to poop. It was very difficult to get stool in a very large cohort and ask them to get it serially. It's just not, our patients who have IBD are not so thrilled about getting routine serial poops, let alone when you feel fine and we're just trying to look for whether it's there. Now, I will show you that the folks we can get calprotectin on were babies. I'll show you about our baby cohort, and that, of course, is a diaper, so baby doesn't refuse for us to use the poop. So that was an easier cohort. They had no say. We just took the poop. But, you know, that was an easier cohort, which is why a lot of what's happening now and a lot of the validation is trying to be done using serum samples, because that's a more scalable way than asking people to poop or getting biopsies in people who have no symptoms. It's just not a routine sort of thing that's going to actually happen. So another thing that was interesting is they found a new antibody. This is alpha V beta 6. So why is this important? That vedolizumab, for example, we're looking at these potentially does that impact the alpha 4 beta 7, although this is different numbers, but it's in the context that maybe there are ways we can measure certain lymphocyte biomarkers as a predictive tool. And they did find that actually these biomarkers are also really differently expressed out to 10 years before diagnosis. So just adding more evidence, these asymptomatic autoantibodies are probably the way to go when we're thinking about a way to implement in our clinical practice in intervention, right? Can we use autoantibodies to take a sibling of anybody that has IBD, put their ultrasound probe on, get a CalPro, do the autoantibodies, determine risk. If you're high versus low, stop smoking, Make sure to have a dog in the house when your baby's born, because there's some research showing that dogs in the first 2 years of life protect you from IBD. Another reason to get more dogs. So, and not cats, because cats have not been shown. Just so everyone's
Absolute must.
oh my God, sorry. Fascinating. The speaker is harassing the audience. So how do we understand it? And a lot of it came from this diabetes framework, which is why I say the fact that it's out there really allows us a framework to start working towards. And if we can even come close to replicating what the immense value of their preclinical prediction and some of their regulatory pathway to actually get a drug approved for the prevention of or for the delaying onset of type 1 diabetes, imagine, right? Especially if pediatrics is one of the fastest growing age groups. Can we actually push it out? Not saying that we're going to eliminate it completely, it would be amazing, but can we push it out? And can we delay, the onset of clinical symptoms or intercept that process early so that no one ever suffers? Kids aren't stopping to grow. Patients are not going to the operating room. Is there a way that we would intervene and use some of our safer biologic-based or immune modulating therapies? And so the idea being is that you start somewhere, which is look how similar this map looks. I mean, you start with the genetic risk, then you have immune, sound familiar, right? Genetic risk, immune activation, autoantibodies, and then the minute you start to get at least 2 autoantibodies, they are claiming that to be the start of type 1 diabetes, right? So you could intervene there in theory, right? That's the whole concept. And I'll just remind you of a recent publication. And then it goes from normal glucose control to abnormal, and then frank diabetes, for example, or what they're calling clinical diabetes. So it's a very strong framework for us to use to be able to also address a similar roadmap. And these are this asymptomatic autoantibodies, which I like that term, that we should be starting to adopt them and not talk about antimicrobial, et cetera, or we're not really sure. We're calling them serum markers, serum antibodies. I think just focusing on the fact that they're present in asymptomatic people, that is the right name, that we should be using these for hours, ASCA, et cetera. But I mean, the idea that you can see that patients who were autoantibody negative really were stable in terms of their insulin secretion, versus you could see that in people progressing towards type 1 diabetes using C-peptide and looking at the AUC, meaning the predictability of getting diabetes, is really interesting. And these are, if you have multiple autoantibodies, how quickly do you progress to diabetes? And this is very similar to the AUC curve I just showed you for the autoantibodies that we're looking at in IBD, that you can almost predict and you get there faster. And what's interesting in IBD, what we also found is not only could you see these 10 years before diagnosis in the US Army cohort, but actually the height of this response gets higher as you get closer to the date of diagnosis. So you may have a level of 10, and then it becomes 100 within the year of diagnosis. So there is a slow progression, and maybe that's in relationship to more inflammation, depth of inflammation, lack of tolerance, et cetera, that we're seeing as you get closer to deeper ulcerations, more symptomatic, transmural and Crohn's, et cetera. So there's a lot of similarities. Now, there's been a few ways that folks have looked at big cohorts. So in Israel, they have this huge epi cohort, incident cohort of IBD patients. They matched it to controls, and they were looking, could you use platelet, like bare bones? You don't even have to do serologies, is what they're basically saying, is that, can you just look at labs, platelets count, looking in children or adults? Are there certain labs that you can find from your Epic and do AI and be able to literally predict this individual is at highest risk of getting IBD, meaning just routine blood tests was their concept, that you don't have to be as fancy as you think, but that routine blood test may actually, which ones will be higher in patients leading to within the year pre-diagnosis, and there's a little bit of a difference between Crohn's and adults. Another really amazing cohort is called the meconium cohort. And of course, that means we got the first stool of life, and which is why I say that we were able to collect it without problem. And this was looking at babies born to moms with IBD, parents, one of the two, but particularly mom was the primary hypothesis because of the shared microbiome, versus babies that were born to moms without IBD or dads without IBD. So into families, and during gestation exposed to the same immune response and microbiome that the mom was, right? I mean, that's the whole shared environment hypothesis with the idea that your immune response gets primed in utero. And so could it be already that the baby is developing differential immune responses? So this is and they've shown that, again, diabetes has really led the way in most of this work. So the meconium was a follow-on to what had been published. But we also get umbilical cord blood, we get placenta, we get breast milk, and we also collect stools up till 10 years of life for all of these babies that were born. So what did we find? So interesting findings is that there was a difference in microbiome, not shocking, that the babies born to moms with IBD had a at-risk microbiome that looked just like their moms who have IBD. And the babies who were born to moms without IBD had a healthy or not high-risk microbiome. And in our world, there are certain bacterial clustering that are part of an at-risk profile. And I'll show you a few that the GEM study had noted. But we also found that fecal calpro in the baby was higher in babies born to moms with IBD. Very interesting. And also over time, no matter, even though by the age of 3, things tend to be much more in sync between the two babies born to moms with or without IBD, there's still always a bit of a higher calpro in the babies. I don't know what that reflects. These are what we're digging into and following these babies to see who of them gets IBD. It's really sort of cool, the concept that we're looking in utero to see whether it changes. And I have another cool in utero story in a sec. This is a pedigree of an Orthodox Jewish family in New York City. Quite a large family tree to go through. But what I wanted to share with you is that we realized that there are clustering to a point where birth order mattered. Meaning, in a sense, the people at highest risk for getting IBD was the second sibling, not the 10th. So what we're doing now is looking at the shared environment, the microbiome between the 10th and the 18-year-old, just like I was saying, and also how it works that the oldest sibling, particularly a female, is often taking care of the youngest babies. So there's a lot of shared environment there as well. So it's like a really interesting, experiment in a sense to really look at shared environment and be able to see why is there clustering. Now, John Fred Colombel did publish in France, in northern France, where there's similarly some genetic continuity and multiple children in the family, and found not dissimilar data that birth order mattered. So again, I'm sure birth order matters because they share similar microbiome, exposures, diets, etc. Right? They're more closely aligned. And by the way, genetics, they almost all have the same polygenic risk score. So it's not like genetics was the reason why we were seeing a cluster. They had very similar genetics. It wasn't like the ones that are younger had a different polygenic risk score. They had the same. So it got down to the environment and the shared microbiome. So that's kind of a cool finding. So let's get into, can we build a predictive risk score? So back to the GEM. So GEM sort of told us that there may be a predictive microbial pattern that is associated with higher risk of developing IBD in that cohort that they presented, those 70 or so cases of IBD. And that there may be the GEM score, which I'll show you, they've upped it beyond the microbiome. They're also looking at calpro and other factors to call it the GEM risk score. So they're taking it beyond just microbiome, but actually creating a score that integrates multiple different risk factors to describe someone at risk and looking at the risk ratio. So when they combined intestinal permeability biomarker, microbiome risk score, as well as calpro, I mean, when you are in the top decile of sort of this conglomerate or composite risk score, I mean, out to, looking at 9 years out, I mean, you had a significant increased risk of developing IBD. I mean, this was not insignificant where you would want to intervene, right? If someone had a 13-fold increased rate and you were in the top genetic and microbiome or GEM score, why wouldn't you, one, put a probe on their abdomen, two, think about interception strategies, right? So that's sort of what's on the table, and there is exactly this happening in the world as we speak, and I'll show you that. But that was the concept of how can we put all of this together and create the most predictive biomarker where we all feel comfortable using a biologic as an example, right? Intervening beyond just diet as an example, or giving or understanding the trigger in that particular patient. Like we know that not everyone has every EBV, for example, though EBV is a very common virus. We know that, but I'll take the conversation I did have about the retrovirus and knowing that it's not everybody that has it, but maybe that explains a subset of patients who get IBD, possibly. Don't know for sure. So by the way, story for genetics is that it really has not been able to be a predictive tool. I mean, it barely does anything it doesn't help us predict treatment response. It didn't help us necessarily predict fibrostenosing. It may not too, which we were very excited. I remember 2001 late breaking session at the end of DDW. I don't know if everybody remembers. And there was like a big press conference on the first Crohn's disease ever being described, which is amazing, but it's only present in about a third of Crohn's patients and very few UC patients. So it can't be used as much other than, yay, we opened up a way, and then the GWAS capabilities came out and we were able to find more than just one gene, right? Because we were using linkage capability, and it was a little bit of different way, not as fast to be able to find genetics, but unfortunately for us, genetics hasn't taken us where we wanted to go. So we do know that if we're going to go in the vein of risk prediction, we need to probably go further. We need a lot more omics and integrate it into and using computational biology integration of all these omics to be able to create the most predictive. But honestly, what is crazy, although I started in this autoantibody route literally in the 90s as that was my fellowship grant, was looking at it in kids to differentiate functional pain from IBD. So we were only scoping kids that actually needed to be scoped. So it sort of does fit with the idea that it's present in people who are more likely to have IBD. There's other studies that have shown that these serologies, the more of them you have, the more risk you are of going to surgery and having complicated Crohn's disease. So it monitors both. It sort of has a 360 ability. So in order for us to find targets of therapies, we have to understand a little bit about what triggers this. I mean, this is the complexity and the holy grail is what are some of the factors that we do know. Now, here is all the possible targets. And the alpha-4 beta-7, which is the target of vedolizumab, which is one of our biologic monoclonal antibodies. And I'll show you the study and end with that, is that that's actually happening, that people are feeling the safety of vedolizumab, which is gut selective, very, no immune suppressive state, no malignancy warnings, that people feel very comfortable that targeting an alpha-4 beta-7 in a very high-risk individual will actually intercept disease. Kind of a cool thing. There's also oral IL-23 receptor. So IL-23 is another class of therapies that we use in cross autoimmune diseases. There's a trial happening right now about an oral IL-23. If the safety profile mimics every other IL-23 and it's a pill, we'll be using it in this preclinical cohort, right? It's that concept that as we get more comfortable with the safety of the therapies we're using and we know work better earlier, can we actually use these therapies even earlier? So the GEM actually started to look at, and they looked at people who had a Mediterranean-like dietary pattern in the cohort. And they actually found that when you take an anti-inflammatory Mediterranean-style diet, you have a health microbiome change. So you get a decrease in the microbiomes that put you at risk for inflammation. And you also get a drop in your calprotectin. So the concept, low-hanging fruit, people, like just give the Mediterranean, everybody with IBD wants to talk about diet. There's even though we're not necessarily leading with it, but I do give them the grace to say, yes, there's probably that in addition to addressing the biologic process is that there is an impact on the microbiome, which may actually impact your symptoms. And it may actually impact calpro, and it may decrease the amount of inflammation in the lamina propria or in the gut mucosa. So we don't dismiss it as much. Now, on the other end of Mediterranean diet, let's talk about the non-Mediterranean diet, which is the standard American diet. And there is a lot of interest now at the role of obesity as an inflammatory driver, particularly in IBD. So there are some, obesity interactions with the microbiome that triggers even more adipose tissue, a lot of more adipokines and cytokines, and creeping fat in Crohn's disease in particular. That's sort of the classic finding is, and guess what creeping fat is? Visceral adiposity, mesenteric fat. Guess what's associated with worsening Crohn's disease and stricturing and surgery? Creeping fat. So the idea that maybe obesity as an inflammatory state is actually associated with increased risk of IBD. So will we be using GLP-1 to prevent IBD? I don't know, maybe. Without a BMI of needing 27, maybe, right? Microdosing, who knows? A lot is happening in the space. I was telling some of the residents that there's so much happening in the space in the world of inflammation that maybe this is all part of the story. So this is an exciting, if there's ideas or if you want to tell me or, ask me about where this field is going, this is going to be explosive across autoimmune diseases, the use of GLP-1, particularly in folks who are at risk. So kind of a cool thing. Glycans, another interesting story that maybe you can give glycan. Maybe you can actually give glycan as a treatment strategy because there's been some association that with glycan, you can actually prevent the production of some of these IgG pro-inflammatory function, as well as prevent T-cell activation. So is there an interest or role of glycans as a possible treatment strategy? What about pesticides and PFAS? So looking at cohorts and looking at exposures way back when you were younger, that was associated with an increased risk of IBD. So is this something primary prevention? Can we actually, more primary within an at-risk population, but maybe all of us should think about it, not just those that are at high risk. But this has been shown, and you can see, particularly with pesticides, the risk is even greater as we've had earlier exposure. Way back exposure, meaning 6 to 10 years ago. So another cool study we did with kids is baby teeth. So baby teeth is like a tree. Rings in the teeth are just like rings in the tree to talk about age and exposure. And you can detect metals, you can detect lead, chromium in the baby teeth. So our collaborator in Portugal, Joana Torres, they must keep their baby teeth because she had a lot of baby teeth. Not just her, I'm saying the country, as a country, there was a lot of baby teeth, not just poor Joanna, but, we looked at the metals, the exposome, and into the second trimester, you could track back exposure. So all of this sort of concept about in utero is like legitimately real. And maybe that's where we should be starting when it comes to these autoimmune diseases. And this was a nice review for anybody interested in the reference, but this is really looking at across the spectrum, across preventative and at-risk measures that if you wanted today in your clinic, when a mom says to you, because our patients will say, what can I do to prevent my child from getting IBD? Number one question in my pregnancy clinic. They already know they've got IBD. That's not, they're not asking about themselves. How can I make sure? What can I do while I'm pregnant and what can I do after? So when we talk about these interception trials, we've asked people, what are you willing to do? Are you willing to get a scope in a high-risk individual? So more than 75% said they would do one stool, okay? Greater than 50 would do ultrasounds, that we still got business. And a third would do a colonoscopy. After we ask them to get calpra, I know that number will go up because they'll be like, just scope me, I'm not collecting my own poop. I know how it goes because that's what actually happens in our clinic. And the majority would do interventions and some would take injections, an oral, immunomodulator. So we have a very captive audience of folks who are really focused on how do I prevent it in my siblings, in my kids, That's probably our biggest question, is that the interventions in kids. So again, where do you implement primary and secondary prevention? As I noted, secondary prevention, I call it more interception because the disease has already basically started, right? It's sort of that preclinical autoantibody, at least 2 kind of concept in diabetes. And then primary prevention would be exercise, the dog, avoid smoking, breastfeed, all the different sort of environmental interventions we have some control over. So there's a couple of intervention studies that are happening right now. This is out of Israel, led by Dan Turner, pioneer trial using the tasty and healthy diet. And I bet all of you are saying, wow, that's probably a really great diet. No, not really. So, it's basically avoiding certain foods that are more pro-inflammatory. It's closer to the Mediterranean style of diet, and it just takes out all foods that are tasty, in my opinion. No, it takes out food that are thought to be pro-inflammatory, and there's a laundry list. It increases the amount of soluble fiber, because, by the way, soluble fiber is good. Insoluble fiber, not as much. So our patients don't get that level of detail. They're like, I was told to stop fiber, and now I'm constipated. This would be like after a hospitalization or whatever, after a surgery. I'm like, oh, no. We wanted you to decrease your insoluble fiber, but actually soluble fiber is protective. There's been some evidence that really helps protect against bacterial sort of translocation. Anyway, so this is ongoing, and what they did is they sort of crossed over where you had your usual diet and then crossed over into tasty and healthy, and then crossed you back over and looked at whether or not, and these are in people, who had a high GEM risk score. So they were using the score I sort of showed you, that composite score, and found the highest risk folk, and we're going in and intervening and looking at the role of food. We went one step further because we are obsessed, obviously, with pregnant mothers, and we gave moms the Mediterranean or anti-inflammatory diet in the 3rd trimester and looked at whether or not the calprotectins are lower, whether or not there's a different microbial pattern in babies who were exposed to a Mediterranean or anti-inflammatory diet in utero versus moms who took the standard, American diet. And we actually showed that there was lower fecal calpro in those babies born to moms with Crohn's disease who were on the diet. And we saw that both at baseline and at the end of intervention. That's ongoing in our microbial-based work. This is sort of piggybacking on the meconium study. This is sort of in parallel, because meconium, we didn't do any intervention. We just got poop, meconium forward. This is about going backwards and applying an anti-inflammatory concept during in utero. So these are the 3 that have been published out there as we end with sort of what does the future clinical trials look like in IBD. Really, the one that has been our guiding line and our North Star was the anti-CD3 antibody in type 1 diabetes. Using the framework that I showed you, they literally took that same at-risk population, at least 2 autoantibodies, and went in and were able to look at that and more of a delay. Question is delay acceptable enough? Are we trying to actually eliminate entirely? So I think that's where the conversation will continue to go. Looked at it in RA, they used abatacept actually, and then also the time to MS, looking at therapies with MS. So I think this concept of prevention, which we talked about in the primary prevention world, versus interception, which is the disease has started and you're trying to intercept it. So what does that look like for us? And what's a framework that we're sort of copying and pasting, I'd say, or thinking about, is that, basically we want to have the high-risk population. We want to screen them with a biomarker that has a good area under the curve. And that's what we're sort of looking towards finalizing and validating. Divide you into low risk versus high risk. If you're low risk, stop smoking, get a dog, take the Mediterranean diet, all the things that I sort of, take more Metamucil, I don't know, add some vitamin D, move to a warm place, I don't know, whatever you want to do in someone who is a very low risk, right? It would be really these primary prevention strategies. But in someone who's high risk, again, where would you divide them in terms of how long before they get the disease versus immediate risk? And that's where really the prevention or interception studies would take place, which is using our tools. We at Mount Sinai have opened probably 1 month ago, the first ever IBD prevention clinic. It is for 1st-degree relatives only. They get stool, they get blood, they get an ultrasound. We calculate their risk score. We do it in live, and we give them all the dietary. We give them a whole educational toolkit on what foods, and then we follow them. And if their calpro is above X and their ultrasound is Y, then they actually get a colonoscopy, and then they actually will get an intervention. So that's kind of cool. So as we evolve this and sort of, we're looking, by the way, for collaborators and for folks who want to expand their prevention strategies as well. And so these are just things that in my pregnancy clinic, which is also part of our intervention program, because I see moms pre-conception and then throughout pregnancy, and talk a little bit about what we can do. Pesticides, by the way, was the other sort of concept during, prenatal, avoid smoking, delivery. This was recently published, and the IBD Journal took a whole volume on prevention, by the way. So it has a lot of sort of what I'm showing you here, but more in different chapters in a large volume of the IBD Journal focused solely on prevention. And the whole story about C-section versus vaginal delivery, that's controversial. I mean, outside of a few countries where they've shown that it's because you're passing through the vaginal canal and you're being primed with bacteria, that felt that that has a lower risk of developing IBD than people who are cleanly come, like as if it's clean to come through a C-section and, like there's no bacteria, so I'm not really sure, but that made it, because in some countries there's been, particularly in Sweden and some of these large databases, they've been able to go back again, all cause and effect, just saying everyone who had IBD, C-section versus vag, and then deciding that it was a higher risk with vaginal delivery without taking into account anything else, right? That's all we know. So I'm just saying that some of it was brought here, skin to skin contact, breastfeeding. Again, this is not always possible. And then of course in the postnatal. So what we're actually doing now, and so GEM and our Road to Prevention, our Meconium and Pioneer, that's all happening in place, but the Europeans are doing a massive, very well funded by the EU grant, looking at finding that biomarker across Europe, finding a predictive tool, and then using that tool to determine low or high risk. I'm sure we'll come down to probably the autoantibodies will remain an important part of that prediction. And as I noted, this is one of their work product 3, which was literally based on your serum biomarker. So again, they recognize that tissue and poop is not going to be the highest yield scalable predictive tool if we want to use it in the clinic. So they really are focused on a serum biomarker panel that is most predictive. And using that, they will give them vedolizumab versus placebo. So we're already that's down the road. Obviously, we have to still find the biomarker. And Frank, you could fill me in if on any scoop that I may have missed. But the idea that first we have to find that biomarker and track it and use it as a prediction tool, and then be able to intervene or intercept depending on where they are on the process. So this is like happening. Like this is not like somewhere in the basement that we're making all this up, which is kind of cool. Like while we're all focused on how to use the new meds and focused on all these new meds that are coming to market, amazing for people with IBD. But the fact is we may decrease people's suffering in another way, particularly in the early preclinical. So in summary, IBD does not start at diagnosis or when the symptoms occur. That is a for sure. And we all know that because we have people presenting with bowel obstruction. Like that didn't happen overnight. They've been having IBD, ongoing inflammation, bowel wall damage, strictures. They just avoided lactose or they changed their diet and maybe lowered fiber, whatever was happening, to get a diagnostic delay of about 2 years, right? Coming to the ED. We have more and more evidence to support that there are serum markers that are up out to 10 years before diagnosis. We know there are multiple pathways that lead to the development of IBD, and we think that maybe there's different predictors that predict different locations of disease, which is a whole other, talk on sort of how our gene expression differentiating why you show up with one phenotype and I show up with another. Like, what is that all about, right? Like, there's not just one Crohn's. That is a for sure statement, and there's not just one you see. So the ability to look at the preclinical IBD and be able to risk stratify. And I really believe that without collaboration, because we can't do it alone, you need a lot of patients to be able to study this and to actually be able to see it. But I think the fact that the conversation has started is really exciting. So thank you.
Thank you very much, Dr. Dubinsky. So much to think about. Just an amazing overview of, I think, where we should be going. So I think we have time for a few questions. Dr. Jayakumar.
Thank you very much. That's a great talk. Oh, yesterday. I have a question. So I'm hepatology and I see fatty liver. So had a lot of discussion about Mediterranean diet. And one of the complaints I get is usually from my patients who may be recent immigrants, especially Asian, South Asian, East Asian countries, is this does not reflect my, culture. This is really difficult for me to adopt. And I'm wondering if there's been any studies looking at the effects or protective effects of other diets, especially I think East Asian diets where there's more fermented foods.
Yeah. So the question about, not everyone follows the Mediterranean, and that's just not their diet, and whether or not there are certain other diets and the way that they use more fermented foods. We're asking East Asian diets you were specifically mentioning. There hasn't really been much comparison outside of the Mediterranean versus standard Western diet, really. There was the EPI-CUR data set from Europe where they were looking at it for predictors of cancer, just so you know, but it was not heavily influenced by East Asian diet whatsoever. So I'd say there's a lot more opportunity. What we do know is that when you adopt a Western diet after eating a certain way for all of your life, that the risk of IBD significantly, exponentially increases. So there must be something protective at some level. So I get asked a lot, oh, should I be adding curcumin or turmeric to my diet? Or I said, well, my diet is full of turmeric or curcumin, and no, because I'll be like, oh yeah, that's probably not the best idea for me to bring up. Like I'm doing something new here. So there hasn't been a lot of work on that. So maybe expanding on what else other than the Mediterranean diet may be protective in different populations.
Dr. Mason?
Well, that's magnificent.
Thank
Quick question about sclerosing cholangitis and ANCA antibodies. In our patients, ANCAs are protected. So in other words, if you have an ANCA, you're less likely to get a liver transplant, you're less likely to get cholangiocarcinoma. And there's this idea that some of these antibodies are also anti-cancer antibodies as well. So my question to you is, do you see the same in inflammatory bowel disease? Do antibodies vary with prognosis and outcomes?
So the more in Crohn's do we have really good data. I'd say more than ANCA and UC, which I'll get to ANCA in just a sec. But in Crohn's disease, the ASCA, particularly ASCA A and G, looking at the number, like what Jem showed, the number, if you had at least two of OMC, CBER, or ASCA A or ASCA G, if you had at least two of those, had the highest risk of developing IBD. But in the PREDICTS cohort, I just showed you the development of IBD in the US Army cohort, those that had the highest ASCA and CBER had complication at the time of diagnosis. So there's not, and that's really where after my whole diagnostic piece scenario, I had to evolve to something that people cared about, which is prognosis, right, in IBD. So the serology part in known diagnoses, everyone's complaint was, yeah, they already complicated. You're just doing a association that someone who had complication had ASCA. Okay, fair enough. But in the PREDICT cohort, we actually said, no, these are in people that you don't even know have diagnosis and a predicted worse prognosis at presentation. Okay, so that we found out that ASCA and CBER are pretty strong prognostic indicators. ANCA, interestingly, has been in the IBD space, has not been protective of anything. It just was used as a way to say this isn't Crohn's, this is more UC-like, right? So it wasn't so sophisticated. It was a UC-like marker, and that's what it became. It was associated, there was no association with responsive therapy because everyone thought, oh, wow, if you're p-ANCA positive, you're worse, you may have more autoantibody or more immune disease, and you wouldn't be as responsive to drug. That study did not show that serologies were tied to response to therapy. And there was no association with colectomy. So I'm not sure, and unlike what you're seeing, which sounds much more dramatic in a good way than what we found with serologies in UC. Yeah, we haven't seen that type of protection or risk per se. Yeah.
Dr. Winchie?
Yeah, what an amazing talk, and this of course raises so many questions. So my concern is a little bit, if you take this whole concept a step further, we have 15,000 people with IBD in just the epicenter. So let's say we take one first-degree relative of every one of those patients, we are already overwhelmed with the system. And the practical consequences is a lot of healthcare will go to healthy individuals. And then also when I see in the general rate 5,000 people at high risk and only like not even more than 100 actually developed IBD during follow-up. So aren't we taking this a little bit too far? And can we narrow it down to like even higher risk individuals to kind of save their precious healthcare?
I think that's what we're looking towards. I think from a public service announcement to be able to just tell people at a mall, which include high-risk people, meaning first-degree relatives, change your diet, less antibiotics. Like this is what it's exactly what I do in my clinic, right? In my pregnancy clinic, you know, get a dog if you don't have one, which is usually controversial with the husband and the wife. I love it. So I'm like, no, you need a dog. I told you we needed a dog. I'm not getting a dog. This is like half of the conversation. So avoid antibiotics. You know, people feel under pressure to breastfeed, and although it's on the list, it hasn't necessarily been 100% predictive that you lower the risk of IBD. And I don't want to make my moms feel bad if they can't breastfeed. You know, that really is the worst conversation to have is you really need to breastfeed because it's been shown to be productive. We can talk about all the possible primary ways that you can counsel the moms or the sibling, meaning the parent, the kid you have in front of you, a 28-year-old, and say, look, proactively, this is what we know about the role of diet. You may want to not only apply it to yourself, but maybe your first-degree relatives, etc. I don't expect there to be too many at the highest risk group, which is what you're basically telling me. How many are high, which is where I think Intercept may actually help us, meaning the big European cohort and us further looking at defining the best predictive biomarker. And in our clinic, you know, we're using ultrasound, we're using Calpro, we're not just using autoantibodies, we're sort of creating the highest risk group. And so I'll be able to tell you how many actually fit into the highest risk group before you sort of open up a clinic for every first-degree relative and have them come through the door. We're starting with referral only. So my pregnancy clinic, we're not ultrasounding the kids until they're 5. I'm not going to put a probe on a 1-month-old. Like that's not happening. So we've limited it to that we're only ultrasounding kids once they hit 5, you know, because looking at the incidence or looking at the sort of timing of when they would get IBD. So I think there's still a lot to be done. I agree with you. Our healthcare system is not set up to give everybody vedolizumab if they're a first-degree relative, 100%. But I think we will get to the highest risk group where we'll be able to intercept the disease. I do believe it. We just need a lot more patients, and hopefully Intercept will help. Yeah.
So I think we'll have to stop for the sake of time. I think we could ask Dr. Dubinsky questions for another hour. So just on behalf of the division, University of Alberta, it was an amazing lecture, our 24th Wensel Sherbaniuk Lectureship. So thank you very much for coming, Tim, and giving an amazing talk.